to be here and see a lot of you again. So thanks again for the invitation. So I thought I would start the meeting tonight and just talk about a few updates in technology and kind of what's going on in radiation medicine, and then switch gears a little bit and talk to you again about Infraguard. And so I'll go through both of those. I do have a few disclosures because I am going to talk about some breast cancer treatments. I'm a consultant for Merit Medical that makes one of the devices that I have here. And I'm going to talk a little bit about gamma tile, which is GT Medical Technologies. So as I said, I'm going to go through some of the updates and kind of tell you about some of the new technologies, new techniques that we are starting to see come online in radiation medicine. Some of those being adaptive therapy, this patient physics direct patient care initiative, AI and machine learning in radiation therapy, a little bit about flash therapy, and then brachytherapy. And then finally, I'll roll into the Infraguard, completely switching gears. So what is adaptive radiation therapy? So what is radiation therapy? What does our treatment process look like in normal radiation therapy? So typically, we'll have a patient that comes in and they'll have a diagnosis. We're gonna get them imaged with our CT scanner. CT scanner is still kind of the standard of care for how we're gonna segment the patient. We can fuse that with PET imaging, with MRIs, with other scans, but they'll get a CT scan. From there, we'll go to segmenting. So we're gonna delineate all the organs at risk as well as the target area. And then from there, we'll go to our planning stage and come up with our treatment plan, how we're gonna use typically the linear accelerator to deliver the treatment in order to treat the tumor and minimize the organs at risk around. Once that's all done, the patient will come in for their treatments, typically multiple treatments. So they'll come in each day, they'll get set up underneath the linear accelerator. We'll take imaging at that time. There's onboard imaging with cone beam CT, and then we'll use that to align the patient and the target and then deliver the treatment. As you might imagine, there's some issues with this whole setup, right? So back before we had onboard imaging, our treatment margins were very, very large because we weren't able to localize the area that we're treating very well. As technology got better, we got better and better imaging and onboard imaging, and so now we can start setting up the treatment, narrowing our margins. However, as I said, as you can imagine, daily imaging and daily patient anatomy can change quite dramatically. So if you think about like a cervical cancer treatment, so you have the cervix that we're treating and around that area, but then we also have bladder, rectum, sigmoid. Those change quite rapidly. Bladder can fill, bladder can urinate and empty it. Same with the bowel and gas. So there are a lot of things that we need to have to deal with on a daily basis that can change quite a bit. So the idea with adaptive radiation treatment is going through that same process, but now when you get to the setup imaging, here at this stage, we're going to image the patient on this particular day. So say today, Thursday, and now we're going to see that the patient anatomy is a little bit different from our original. We're going to loop this back in to an auto planning and auto segmentation and deformably use some deformable image registration to change our plan and adapt it while the patient is still there on the table, and then deliver a more customized treatment to that patient. And in that way, we can shrink our margins, minimize the dose to the organs at risk around that area and maximize it to our treatment target.
Can I ask a question? Or should I wait till the end? Or
Please.
I was going to ask, what kind of, I can think about 4 or 5 different kinds of imaging, from PET scans to CAT scans to MRIs to X-rays. What do you mean by imaging?
So typically on our linear accelerators, we have imaging panels, so it's going to take a cone beam CT.
It's going to be
So it's a
CTs.
CT scan, yeah.
But not PET or not
No.
not MRIs?
There are MRIs, yes. So I'll talk about that. I have it in a slide in a second. So how did we get here? You know, some of the previous things that we've worked on is you know, we saw this before we had the technology to do this auto planning, auto segmentation on the fly. A lot of people had thought about how are we going to try to do this, and so you know, a lot of times one of the first experiments we tried was coming up with different plans for the patient. So we would have this original CT scan. We would have a patient with a full bladder, and then scan them with an empty bladder, and then use that, and then we would figure out, okay, once they came into treatment, which one was closest to that patient's daily anatomy, and what would be, you know, where the target and organs at risk were. So, yeah, so this really condenses, you know, days worth of work into 15 to 90 minutes, depending on how complicated the case is and how long it's going to take to do the image registration and planning part. So what do we need to do it? We need onboard imaging, like I said, so we need our treatment machine to have some sort of imaging technology on it. A paired treatment planning system for this rapid recontouring of the patient anatomy and the target, and then plan re-optimization. We also need pre-treatment quality assurance, right? We need to make sure that we're delivering the proper dose to the patient, and you really do need an enthusiastic team because it is quite different from what we're diverging from where we were, and it's much more time consuming and labor intensive, but obviously with much better efficacy. So why now? Because we're starting to get the technology that we can actually do this. So we have high quality onboard imaging, we have really fast optimization. The graphic processing units, GPUs, that have come into play have really helped speed up a lot of the processing time. And we can do pre-treatment QA very, very quickly on these machines. So now we have these single integrated systems with AI support. So 2 of the MRI guided ones are the ViewRay Meridian Elected Unity. So these are MR linear accelerators. So it has MRI with the linear accelerator. And then KV cone beam CT guided is the Varian Ethos machine shown here. So there are a few different ones out. Why should we bother? Like I said, it's taking extra time, up to 90 minutes per patient, because we really want to give as much dose to the tumor as we can and minimize that risk of overdose to the organs at risk. So we can track the day-to-day anatomical changes and reduce those margins. So we're shrinking and shrinking those margins so that we're just really focusing that radiation on our target and really trying to minimize it to the organs at risk. So here, this is, just an example motivation for adaptive radiation therapy. So here's a non-adapted dose distribution. So here, showing the red, that's our target, and it can move out of the field, right? So it's moving out of the field. It's moved up in this picture, anterior, and so when that happens, our organs at risk can move into the field and vice versa. And so now, if we do that adapted dose, we can adapt it to the patient's individual anatomy for that day and get a much better dose distribution. So again, one of the big ones that we use for is cervical cancer treatments. So you can see here the difference. Here's the simulation CT and MRI, looking at that target volume. And then as we change on the day, we're going to re-optimize to that new target. So let's see. This is just another one. So yeah, so for this example here, now we've reduced to 3 millimeter margins compared to our standard of care, which was 5 to 15 millimeter margins. It's a very, very large difference. Here's another one, just showing differences in patient anatomy in the cervical cancer patient with the uterus and ovary movement. I have a video here just showing the changes in day-to-day motion have changed over. Now this is a prostate cancer patient, but you can see rectal filling and how that changes, especially with the gas. That's good. And how if we don't adapt, we're gonna miss the target and overdose the surrounding normal tissues. Not overdose, but they're gonna get more than we intended. Again, lymphoma patient, just again showing the differences though. So this is just the changes, daily changes that can occur. Follicular lymphoma, again here this is at our initial CT scan. This is on fraction 2, fraction 4, 6, 8, and 10, and you can see the movement and change in the target. And again, ovary, cervix, and the changes in day-to-day, the migration of our target. So this really gives us the opportunity to shrink margins. So I'm going to switch gears now. Physics Direct Patient Care Initiative. So one of the new kind of initiatives that's coming through our institution as well as AAPM is looking at a different role for medical physicists in the field. So this really establishes a role of medical physicists having consults with patients. So with patients, providing technical explanations of the treatment process, treatment planning, delivery, safety, and it's, the goal was to improve patient understanding and reduce treatment-related stress. So we did have a phase 3 clinical trial that was conducted at UCSD, and it ultimately showed that this direct patient care can reduce patient anxiety and increase satisfaction with radiation therapy. So the patients that received these consultations experienced significantly lower treatment-related anxiety compared to the control group by the first treatment. They reported greater technical satisfaction throughout their treatment course from simulation to the last treatment session, and overall satisfaction was significantly higher for these patients at both the first and last treatment time points. And there have been plenty of studies that have showed that the more comfortable patients are during their treatment, the better efficacy of the treatment. So what does this look like in practice? So part of the trial was we had our medical physicist, they would meet with the patient right before the simulation when they got that first CT when they entered the department. And then for the trial, then the patients had a questionnaire after the simulation to see how they felt. And then they would get a second physics consult before the first fraction of treatment. And then they were surveyed after that. And then they would have a third questionnaire just after their last treatment fraction, again, to see how they felt. And that was part of the trial. We still continue to do these patient consults, again, before the simulation and then before their first treatment. And what does it look like? So we have some infographics, kind of these cartoons to explain the process of radiation therapy. So we have the scanner. We try to break it up into how it creates these slices, which gives us our images, how we use those images to reconstruct a three-dimensional body, contour our target and the organs at risk, how that goes to planning, talk a little bit about our X-ray production and dose, how it destroys cancer cells, and how we deliver it in these infographics. The Health Physics Society has always had an amazing Ask the Experts section and question and answers. I'll tell you that AAPM now has some public education information out there. It's at medicalradiationinfo.org. You can get it with the QR code now. There is quite a bit out there recently about the harm of radiation. You see it more on the diagnostic side, and so this was an infographic, very recently produced, that you might see on social media in the next few days, trying to get out there, to really encourage patients that they still need to continue with care. The risks, especially from diagnostic imaging, is very low compared to the benefits. But there is an Ask the Experts section on this medicalradiationinfo.org as well, and just trying to get more information out there to the public. Switching gears a little bit again, so AI and machine learning in RT. So, as with almost everything that we see now, AI has become a part of our lives, and we're seeing it more and more. And as I talked about with the adaptive radiation therapy, we're starting to see a lot of this with everything from as soon as you have that scan, we can get it auto-imported into our treatment planning systems. We have auto-contouring tools that will auto-segment your head and neck or whatever body part you're looking to do, and then auto-plan. It'll come up with the optimized beam angles and how we're going to deliver it, along with an auto-plan check. It's really going towards full automation with one button click. We are very close. Seems like it's been something that we've been talking about for quite a while, but there are a lot that have it out there now. There's a group out of the Netherlands that has been trialing it on patients with basically one click, start to finish treatments. John Hopkins has a group as well with a single button click auto planning. So we're very close to some interesting times. Another new technology, flash therapy. So some might have heard about this. So flash radiotherapy, it delivers ultra high doses of radiation in just a fraction of a second. So how fast? So we're delivering a complete therapeutic dose in about 0.3 of a second. Extremely fast. Just like that. It first started with electron beam therapy, but as you know, electrons don't penetrate very far, and so to put that into patient use, there's been experimentation moving forward. A lot have looked at proton therapy and doing flash with protons. There have been a few groups now that have conducted trials in humans with flash therapy and protons, showing good control.
I got a question.
Yes.
Besides control, knowing where things are and hitting it when it's there.
Yep.
Is there a biological difference as far as you know from your experience between having a super acute dose versus having a protracted dose that cell repair goes on during that time?
Great question. You beat me to the punch.
Oh.
So yeah. So this is it's really interesting with these ultra fast. So they're finding that it spares normal tissue, and that was in all the animal studies. They found that there was much more normal tissue sparing. So you got the same therapeutic dose, but with a lot more normal tissue sparing. And the jury is still out as to how that is actually happening.
That's very interesting.
Yeah, it's very interesting.
And what is flash? What's the time? You say a fraction of a second?
Like 3/10 of a second.
That's fast.
So yeah. So your whole therapeutic dose in just that blink of an eye. So we are going to start seeing a lot more, I think, around flash therapy as more and more experiment with that, but you need specialized machines, specialized equipment. So it's not at every site, but we'll see, especially as we start to see the radiobiology behind the effects and how it's the mechanisms with that. But they're seeing a lot less normal tissue damage while still getting the tumor control. And then finally, brachytherapy. So what is brachytherapy? Close distance therapy, right? So we're implanting a radioisotope in, on, or around the target area. These can be permanent implants or temporary implants. And again, how I always talk to the residents, they're like, oh, well, implanting these, they did that with radium since 1900. Why? Now we've got flash therapy, proton therapy, carbon ions, all these new great technologies. Why aren't we using those? Because it is still, I would say, the most conformal treatment that we can possibly give. You're getting that radioisotope in, on, or around your target area. You've got your 1/r² dose fall off, so it's sparing all the normal tissue around, and we see the results, right? So this is a schematic. This is a group that has collected data from all sorts of prostate cancer treatments. So this is for low risk, but they have the same graphs for intermediate and high risk. So this is success of treatment, how they measured with years after the cancer treatment, and we see they have robotic prostatectomy surgery, they have seeds, they have protons, seeds alone, high dose rate brachytherapy, surgery, EBRT, external beam radiotherapy, HIFU. The main takeaway is that brachytherapy always lands up at the top, whether that's seeds or seeds in conjunction with EBRT used as a boost. Brachytherapy is always at the top. This was a paper a little while ago, trends in the utilization of brachytherapy in cervical cancer in the United States. Brachytherapy is still standard of care for cervical cancer treatment. And right here, this one line in the conclusion sums it up. That brachytherapy use is independently associated with significantly higher cause-specific survival and overall survival. and should be implemented in all feasible cases. So again, yes?
Do you ever have any problem obtaining the radioisotopes you need for that particular type of therapy?
Not typically. So typically with cervical cancer treatments, this is high dose rate. So this is with an afterloader using iridium-192. So typically we'll have, there are a couple manufacturers that have high dose rate afterloaders with the iridium-192, and that's switched out usually on a quarterly basis. Seeds, every once in a while there's been some production problems and you'll get some delays, but overall it's pretty stable as well. So different kinds of implants, right? So we can do breast cancer implants. So this would be interstitial implant. You would have multi-catheters across the implant area, the treatment area. You can do the same thing with a single entry device. I brought one people can see. So this was made to make it a little bit easier than this process and a little better cosmetic outcome. So this is, you can crank this down, so now you would just have one single incision. This is placed into the tumor bed. You would open it up, and then that would fill the lumpectomy cavity, and then the iridium source would come into each of these channels to deliver the dose. Prostate implants, so we could do prostate implants with seeds. We could also do it with high dose rate afterloader as well. Similar process for that, just inserting the needles, whether you either keep the needles in and use the high dose rate afterloader to deliver the treatment, or drop the seeds and leave them in place. So this would be our permanent implant, whereas the HDR would just be one or two fractions. A newer device on the market, it's been out a couple years, but I think they've treated now, it's pretty high, it's like 1,700 patients for different brain issues. So from glioblastoma to recurrent Mets. This is a tile, it's a collagen tile, and in that tile there are 4 seeds of cesium-131. So it's got a 9.5 day half-life, and so those would be implanted. So you would do your craniotomy, resect the tumor, and then place these tiles into the resection bed and leave those permanently, and it would deliver your dose over the next several weeks. So the tiles here, the seeds are actually offset in the tiles so that you get a little bit of sparing to the normal tissue in the brain from the offset using your 1/r squared fall off, and then the hot side would go towards the tumor area where there might be some microscopic disease left. A few other types of treatments we can use. So these are all high dose rate using our afterloader. So a lot of skin cancer treatments, sarcoma treatment, basal cell in the lower lip. We can do different molds, 3D printed molds. So this is a 3D printed mold of the nose where you can see the channels coming across. This is a hand. So a lot of different options with our brachytherapy, from, like I said, brain cancer to prostate cancer, breast cancer, skin cancer. All right, that's some of the updates from radiation medicine.
Can I ask one more question?
Of course.
I've worked with radiation safety officers for medical facilities like hospitals. And the question came up, if you have a patient who passes away with a brachytherapy source inside of them, like what is the protocol for that?
Oh, I can answer that. Because the ME is right here. So we did have some patients that did have implants. So when it gets to their the care home or the healthcare facility notifies the ME, and then they hold the patient at the morgue.
Okay, so the hospital doesn't need to hold them
No.
on site.
No.
They would let public health know and public health would do it for them.
Yes.
Okay,
Yeah, so
excellent.
that
Thank
has
you.
happened. Yeah. It's usually actually the care home
Yeah.
that notifies us.
Yeah, and APM and I think it was ACR, they had a position statement as well as far as cremation and holding the body and burial and kind of guidelines for it. But typically at the hospital, yeah, we will try to follow the patient as well in order to make sure that everything's coordinated and we're watching that.
Thank you.
All right, finally, switching switching gears again a little bit to Infraguard. So I want to give a little plug for this program again. So Infraguard, I'm gonna read it because it's easier. It's a partnership between the FBI and members of the private sector for the protection of U.S. critical infrastructure. And so this is the Infraguard San Diego. So there are chapters all over the country. And so you can become a member of the local section. And it's this partnership between the FBI and members of the different critical infrastructure in that area to try to help support safety of those areas. So what are the critical infrastructures and why are they important? So we have chemical, commercial facilities, communications, critical manufacturing, dams, defense industrial base, emergency services, energy, financial services, food and agriculture, government facilities, healthcare and public health, IT, nuclear reactors, materials and waste, transportation systems, water and wastewater systems. The FBI is relatively small, and they can only do so much. And if you look back at the website I have here, so the San Diego one, as well as the national one, there's this little button up here, Suspicious Activity Reporting, so SAR. So they really rely on people to help them with the suspicious activity reporting. It goes to the San Diego Law Enforcement Coordination Center, SDLECC, and they take those seriously. And they'll take those and run with it for their investigations. So, why is it important to us? Here, these are probably the ones that we're most familiar with, right? So, the recent electrical stations, there have been incidents across the country where people have been usually shooting at big transformers and taking them out and getting rid of power to large sections. This was one in Norway. Actually, somebody snuck onto a site, drained the oil out of a transformer and contaminated the area with the oil as well as taking out the transformer. And I don't know how many remember, but the 2011 Southwest blackout, when we had people, I had a physician siphoning gas out of a car in the parking lot because somebody else was out of gas and didn't have power. So this was 2011, right? They blamed it on one worker who was out in Yuma, and took out the entire power grid for, I think it was like 4 or 5 million people? But that was just an accident. That was nothing nefarious, right? And so we look at these and it's like, wow, how does that relate to us? Why am I talking about it? Hey, look at that. So everything I'm showing, by the way, this is all not confidential. This is all open source that I've got. If you become part of Infraguard, you will start getting more confidential information. This was Arizona, right? So this was a guy, I think at the time, he was about 20 years old. No red flags in the past. Stabbed a worker at a store, went back to his work where he did industrial radiography.
Oh.
Grabbed an iridium 192 source, decided he was gonna not do an RDD, but radiological device. He was gonna leave it, like under the chair at some place, and then exposure device, radiological exposure device,
Yes.
and leave it. Ultimately, that didn't happen, and he was going to have a last stand with the FBI and law enforcement. Ultimately, that didn't happen. They were able to contain the source, contain him, but he just got, not too long ago, 15 years in jail. So, it does happen. It does happen in our field, in our area. So as I was saying, some of the benefits of membership, there are chapter meetings, there are quarterly meetings where you get a lot of information, invitations to different seminars, conferences, tabletop exercises. There are a lot of FBI and government agency presentations to members. You can go to this Infrastructure Liaison Officer course. So that's held at the Law Enforcement Coordination Center, where they talk about, it talks about infrastructure and how it relates to terrorism, espionage, cyber attacks, and what we can do and how we can help them with this suspicious activity reporting and kind of notifying them, right? So then chemical sector is a really easy one to look at for examples. So, as we see a lot of precursor materials. So, if you're working in the chemical sector and you're part of the program, a lot of times the FBI will reach out and say, hey, these are different precursors for the new drugs that are out on the market in the San Diego area, for bomb-making materials, things like that. We would appreciate it if you could submit a report. If you start seeing unusual activities of people buying things, right? So easy things like that. For us, hey, maybe it's, all of a sudden you're receiving pet materials or a new source and people start asking questions. Oh, hey, when's your next delivery? Oh, hey, what are you doing? Taking pictures of your facility, things like that, right? These are all things that, with the totality of circumstances around, maybe it's normal, maybe it's not. But these are kind of the things that, might be useful. We're living, unfortunately, in some kind of turbulent times. I won't talk about politics, but we do have a lot of enemies, and foreign and domestic. And so, people do want to do harm. Hopefully not radiological or chemical or any other. Membership requirements. So there are just a few things. You can find this on the web page, and I put a QR code here. If anybody, this goes directly to the membership page, and then you can search around and find different information. But that is how to join. It would be great. The nuclear section in San Diego is very small. It would be great to have more people on board. this program, Infraguard, it's more towards prevention. There's, you could go on for a long time on different programs. There's Radiological Operations Support Specialist, ROS. That's more for the mitigation if something happens. So I'm not going to go down that road, but hopefully we can help with some of the prevention. So that's kind of updates for radiation therapy and my plug for Infraguard program, and hopefully have some new membership. And if there are any questions, I'm happy to help.
I do want to say just thank you for the work you're doing, because I worked as a clinical research coordinator at UCSD. I worked with Dr. Lauren Mel with head and neck, and love that guy, he's crazy. But, I guess I was very honed in on the medical side of it, so immunotherapy treatments, that I didn't even realize that there were improvements in radiotherapy happening, because, it's the scientific method. You change one variable, you have to keep the rest the same. So it's just so amazing to me that they're, obviously the body moves internally every day. Why didn't I think of that earlier, that kind of thing, which I think is just super cool and incredible. And I do think that the program you were talking about, having the health physicists speak to the patient, is also amazing, because there's so many patients. There's only so much time in the day. I've seen so many of them get just shoveled through the system, terrified the whole time. And I think any intervention to get another friendly face to explain, hey, this is what's gonna happen, we're gonna do our best for you, is absolutely a gift to these patients. And yeah, anything to make it not seem like the death sentence it was 30 years ago, and it's not. But yeah, and that's thanks to you and people like you, so I appreciate you.
Thanks. Thank you. Yeah, it's that part of the program. It's really nice. It's really nice to have that interaction. Usually you're behind the scenes, and to be able to talk to the patients and explain that, because I'm sure we've everybody, you get that question: am I radioactive? Can I go hug my kids? Is my child radioactive? Right? You get a pediatric scan, and somebody comes back and they're like, is my child radioactive? Can I go near them? I mean, that's terrifying, and that's terrible. And so, the more that we can interface with them and try to dispel those things, especially with hopefully the information that's coming out from Health Physics Society, from AAPM, to try to address that. I didn't, the updates too, I didn't even get into the immunotherapies and the radiopharmaceuticals, because that is just taking off, and that is another area that is just gonna continue to go up and up and up with the procedures and the different things with it, the lutetium-177, with the Xofigo, with the radioembolization, the Y90, all these things. So we're just going to see more and more of these procedures, I think, and changes with those. So I think more and more interactions with physics.
Yeah, I mean, the immunotherapy is getting to the point where, it will get up to the point where it's personalized to you, which I think, obviously, it's not gonna happen tomorrow, but I think that's incredible. So, very cool stuff. Thank you.
Thanks.
Any other questions or anything?
I do have a question. Was the patient interaction program, was that started at UCSD, or is this kind of an industry or professional model that they're trying to implement?
It's transformed into a professional. So we were, so Todd Atwood at UCSD was one of the first to really to trial it and kind of pioneer it. But now it has become more of a standard APM is really trying to push forward with more of that model and encouraging. It is hard, right? It's a lot more work. And so part of the issues with a lot of places is just the bandwidth, right? So you're doing all your normal medical physics work, and now you have this on top of that. So I think it's just going to be a transition, but I think it could be a nice niche to fill, especially as we start seeing maybe more automation and planning, and things get a little bit faster. Maybe hopefully that takes a little bandwidth, frees up a little bandwidth to start doing some of these other things. Thank you.
All right, thanks for coming.